at the top of the hour. Welcome, everybody. Thanks for joining us for the webinar. This is possible through the Nursing Home Social Work Network. And right there in front of you on your screen, you'll see the URL. On the website, we keep handouts for all these webinars, and we also have recordings of these sessions. I'd like to welcome nursing home staff members and supporters of enhanced psychosocial care for all nursing home residents. Our information is geared toward nursing home social workers, but anybody in the nursing home can benefit from the information, and frankly, anybody who's interested in psychosocial issues of nursing home residents. We think this information is going to be useful. We offer 2 webinars per month. Our Tuesday webinars are around the area of skill building, and the webinars presented by social workers to social workers and to others related to best practice nursing home social work skills. And then our Thursday issues, we have speakers from a variety of backgrounds who talk about contemporary issues in long-term care. So we welcome you to join us either the Tuesday or the Thursday or both. There's a chat box on your screen. Please type in any messages if you're having some problems hearing or anything like that. And then there's also a question and answer box that says Q&A. Go ahead and put your question in there if you'd like. Our presenter is speaking, I'll be checking the Q&A box, and if there's a question I think I need to interrupt the speaker with, I will. Otherwise, we'll be keeping the questions until the end of the session. And then we post the recordings on the University of Iowa School of Social Work's website in about a day. We're going to start with a bit of a welcome, and then there'll be an introduction of our speaker. The speaker will present for about between 50 minutes and 60 minutes, and then we're going to reserve the last 15 minutes for your questions and any comments that you may have. So in all, we're planning for about an hour and 15 minutes. I'd also like to acknowledge the generous support from the Retirement Research Foundation. Have funded us to produce a series of 15 months of webinars for nursing home social workers. And also like to acknowledge the assistance and support of the National Plan Committee, people from around the country who've been working with me really for the last year and a half to make this series possible. I'm going to turn the microphone over to Robert Conley, social worker. He's got 20 years experience at the Center for Medicare and Medicaid Services, and in fact, he was the project officer, MDS 3.0. He's a plan committee member of this network, and he's also co-leader of the webinar project. So, take it away.
Okay, thanks, Merce. I'm really happy to be here today. As my bio indicates, I worked for the Center for Medicare and Medicaid Services, and one of my take-home messages was really to let social work know about current policy that impacts on them and impacts on the residents they serve. And today, we're fortunate to have Rizzo, who is an associate professor and is going to speak to us today on the Affordable Care Act. Background includes doing research and examining healthcare, impact of social work interventions on older adults with chronic illnesses, elder abuse, and the demands of the informed caregiver. She's partnering with Jewish Association for Services to the Aged in New York City, which is a large agency, to conduct research focused on the provision of social work services to older adults participating in their programs. She did her MSW and PhD from the State University of New York at Albany. So I turn it over to you.
Thanks. So great to be here today. I'm having a little bit of difficulty with my webcam, so I'm going to turn it off. So to talk about the Affordable Care Act. Oh, I don't know what happened to my slides. Let's see here. Here we go. Something about this webinar is to provide an overview of the main components of the Affordable Care Act, which many of you know has gotten lots of press this week with the House Representatives wanting to totally defund it, and then Senator Cruz doing a 2.5-hour, 21-hour filibuster in the Senate. So we'll talk about the Affordable Care Act within that context, and also to identify and discuss the implications of the Affordable Care Act, which is also known as Obamacare, for social work practice, with some specific attention to long-term care social work, keeping in mind that although the Affordable Care Act has made some changes to Medicare, this was not Medicare reform. It was more of a overall health care reform. The things we're going to look at are, why do we need health care reform? And how did we get here? How did we get to the Affordable Care Act? What are the provisions of the Affordable Care Act, and what has happened so far? Health care reform. Prior to the Affordable Care Act, there were 47 million people who were uninsured, and this number has increased due to the recession and people losing their jobs. Since in our country, health care insurance is very much linked to employment. The number one reason for bankruptcy in the United States is catastrophic medical crises. This is not true of any other developed nation in the world. There's no other nation where people go bankrupt because they cannot afford the medical bills from catastrophic injuries or illness. The cost of our health care is escalating every year. To give you an example, in New York State, Medicaid alone is 25% of the operating budget of New York State. The U.S. has the most expensive health care system in the world, yet ranks 37th in overall health, according to the World Health Organization's rankings. The number one ranked country in the world is France. Actually, some developed countries that are ahead of us in the rankings. Also, as many of us know, because we work in long-term care, the population of older adults, 65 plus years of age, is going to double by to 7 million by the year 2030. And there are people every day turning 65. Also, the healthcare system is fragmented. It's very focused on acute care versus prevention, and I'm sure that there are many other things that we can think of that need to be changed in this system. How did we get here? The very first prepaid hospital plan was at the Baylor Hospital, and it was a self-insured plan. So one of the best books to read on the development of the healthcare system in the United States actually is Paul Starr's book, The Medicalization of Healthcare. He talks about this first prepaid hospital plan. The medical association in this country actually was very good at professionalizing medicine, and so when Baylor developed a plan, they had physicians, they developed a hospital, and a way for them to have income for the hospital. In the 1930s, Roosevelt, as part of his new deal, had proposed universal health care. He was told, however, by the leaders in Congress that if he left the universal health care provision in the New Deal would fail, so it was taken out. So our system developed as an employer-based health insurance system. In the 40s and 50s, it was a very cheap, expensive way to give employees benefits that cost very little money. So that is how we started to have our employee insurance. By the 1960s, most people were covered by their employers. A couple of exclusions. Once people retired, they didn't have health insurance anymore since it was linked to their employer. And children and women who were pregnant and the very poor, those who were unemployed, did not have access to health insurance. So in 1965, under Lyndon Johnson's leadership, Titles 18 and 19 of the Social Security Act were passed into law. Actually, the last major health insurance, health reform that we've had since Obamacare. In 1965, we had some of the similar problems that we're having today with the chaos. Congress was not entirely happy. I actually gave a presentation this morning at a nursing home for a geriatric certificate program, and one of the other presenters was a physician in his 80s. And I was talking about the chaos surrounding the passage of the Affordable Care Act, and he came up and told me a story afterward where he said in 1968 he came back from the war, and he told by a physician, a practicing physician, that the golden era of medicine was over because of Medicare and Medicaid. And he said there was chaos for a couple of years, and then 3 years passed, and he never really saw how it negatively impacted his practice. And under Nixon's leadership, we passed the Health Maintenance Organization Act, which is for managed care. And then, of course, in the 1990s, Clinton, under his first presidency, to have health care reform under Hillary Clinton's leadership, which failed. So then in 2010, we had the passage of the Affordable Care Act, which is also known as Obamacare. So what are the goals of the Affordable Care Act? So the goal was to expand coverage for individuals in the United States. So it's predicted that the Affordable Care Act will ensure 30 million more people by 2014. We'll head through employer-based insurance, still as a major player. We will have health insurance exchanges, which states can choose to develop on their own. They can decide they don't want to develop on their own and have the federal government development for them. So health insurance exchanges are really they're net-based, much like Medicare Part D, the drug program. What you can do is you would go online, go to a health insurance exchange in your state, and you would be able to select from a variety of health insurance products that have different levels of coverage and, of course, different premiums. The other way that we are going to give people access to health insurance is through a Medicaid expansion. So 50 states, those states who opt into the Medicaid expansion, individuals who are up to 133% of the federal poverty line will be eligible for Medicaid. And it is based on federal tax income for this expansion. States choose to the federal poverty line higher. For example, in New York State, the Medicaid expansion, people up to 200% of the federal poverty line will be covered. So people from 133% of the federal poverty line up to 400% of the poverty line will, who fall into Medicaid but may not be able to afford insurance on the open market, will get subsidies to help them afford insurance. The goal of ACA is to control care costs. The annual law, ACA, will cost about $938 billion to fully implement. But the GAO, the General Accounting Office, also predicts that over the long haul, it will reduce the deficit by $124 billion. Long-term care and older adults, one of the major provisions of Medicare, which has already come into effect, is that to decrease drug costs for individuals who are enrolled in Medicare Part D. So one of the flaws, of course, Medicare Part D is the donut hole. So in 2020, part of the Affordable Care Act is to close the donut hole. So there's going to be this period of time where people have to pay 100% out of pocket for their drugs. The other is to improve the healthcare delivery system. Ways to do this, they have the Patient-Centered Outcomes Research Institute, which looks at comparative effectiveness research. There's going to be given through from the federal government to look at the effectiveness of research that has already been done. So if you have cell interventions that have been done, for example, geriatric depression, they will look at the effectiveness of each of the interventions and make some decisions about which ones are more efficacious and also more cost effective. And then there's for Medicare and Medicaid innovation, there are going to be grants, which some of them have already been announced and have been funded, for accountable care organizations, patient and medical homes, and coordination. What we're trying to do is take the most expensive people in the system, talk about the dual eligibles a great deal, those who are have Medicare and also receive Medicaid benefits, coordinate their care so they have fewer transitions in care and they stay out of the ER more often and their medical status is stabilized. The foundation of the Affordable Care Act is the individual mandate. Individual mandate says that all U.S. citizens are required to purchase health insurance beginning in 2014 or to pay a fine. So the act occurring in Congress right now is very important because the open enrollment date for January 1st, 2014 is October 1st of this year, meaning next week. So individuals do not have insurance through their employer, they're not eligible through the Medicaid expansion or through standard Medicaid. They can go to health insurance exchanges to purchase their health insurance. If individuals do not purchase health insurance, they will receive a fine beginning in 2015. The fine will be 1% of income as reported on the federal income tax return, or $95, whichever is greater. And by 2016, it will increase to 2.5% of your income, or $695. Now, this is a very controversial part of the law. Well, it is the United States Supreme Court in June of 2012 said that the individual mandate is constitutional because it does not fall under the Commerce Clause. It actually is a tax. The penalty is a tax because it is managed by IRS, which is a very important part of the Act. In order to enforce the fine that's attached to the Affordable Care Act, the Internal Revenue Service is going to need to have increased funding because they are going to be managing the fine. And this year, they actually Congress estimated that about 3.9 million people will pay the fine in 2016. And individuals up to 400% of the federal poverty level will be eligible for subsidies. So for those of you who are familiar with the Earned Income Tax Credit, for health insurance is going to be very similar. If you get a subsidy, you will get a credit on your tax return. Now, some people would argue that this fine is not incentive enough for individuals to purchase health insurance. Health insurance premiums for a family for a year can be upward between $12,000 and $14,000. So if individuals have to choose between putting food on their table and paying their rent or purchasing health insurance, and they know what their fine might be, are some individuals who argue that 1% of your income, or $95, is not going to be incentive enough for some individuals to buy health insurance. So the provisions. There are, as I stated earlier, expansion of public programs. Medicaid eligibility will be expanded. The Supreme Court did rule in June of 2012, however, national law, federal government mandated that all states had to expand Medicaid under ACA. The Supreme Court said that mandate was unconstitutional. It actually caused the states undue burden because they were only given 1 and 2 years to set up health care exchanges. Even 100% of the cost of the expansion will be covered by the federal government. So 20 states support expansion and are going to take advantage of the 100% of federal funds to expand their Medicaid program. There are 15 states chosen to oppose it, which means Medicaid will not be expanded in their states. Individuals who fund federal poverty guidelines are not going to be eligible for Medicaid in those states. And 5 states haven't made this decision yet. It starts next week. So exchanges. Exchanges are not designed to replace employer-based insurance. So most people who are employed full-time will still continue to get health insurance through their employer. Because employers will be fined if they do not provide health insurance for their employees. So if you do not have employer-based insurance because they're working full-time, there's less than 15 employees in their business, or don't qualify for Medicaid, can buy from private insurance through state-level health insurance exchanges. States should set up their own exchanges or have the federal government set them up. So 17 states and Washington, D.C. have set up their own exchanges. 20 have defaulted, and they want the federal government to set up exchange for them. The system is supposedly going to be seamless, but if you're in a state where it's the federal exchange, you're not going to really see any differences than if you were in a state where your state is managing your exchange. Now, to participate in the health insurance exchange have for 4 different plans. So there is the bronze plan, which must cover 60% of your medical costs, and also are called the 10 essential services that must be in every single health insurance plan that is offered. And this level, there's the platinum plan, which cover up to 90% of your medical costs, plus the 10 essential services. They're not advertised very much, which is why many large employers and some county employers are not happy with the affordable. If you are an employer who offers platinum level plans and gold level plans, because you're offering a high end product, you actually pay a tax. So in some ways, that's a disincentive for employers to provide good insurance. So provisions. There were changes to private insurance 6 months after the enactment in 2010. Insurers were required to offer and renew coverage for any applicant, which means guaranteed issue, and also cover children to the age of 26. So any parents who have children who are 26 years of 26, their children can be covered on their health insurance as their family plan. Also, months after it was enacted, it was prohibited to rescind coverage and a waiting period is greater than 90 days. And at that point, children could not be denied coverage due to pre-existing conditions. One of the consequences of that particular coverage provision is that you had insurance companies that provided child-only insurance coverage. So for parents who weren't eligible for Medicaid, but they couldn't afford to buy insurance for themselves, they could purchase insurance policies for children. But this pre-existing condition clause, this is why health insurance companies went out of the child-only insurance business because they had as cost prohibitive. So under the Affordable Care Act, that is very important, is that insurance companies must spend at least 8 to 80 cents of every premium dollar that they get from a consumer on health care costs. So if I pay $135 a month, my premium, 80 to 85% of that premium should go to pay for health care costs, meaning it should not pay for administrative costs or overhead. For insurance companies, if they don't do that, is that they have to give their customers a rebate. Insurance rebates actually were given back to individuals in 2012. And then 14, what's going to happen is there will be no denial of insurance coverage based on pre-existing conditions, which is why the individual mandate is critically important. You have to have all the healthy people as well as all the sick people enrolled in order for this to be sustainable. There's an elimination of annual and lifetime benefits. No more once you hit $1 million, your coverage is cut off. And there's this inclusion of 10 essential health benefits in all plans, including the bronze plans. So every insurance plan in the country now will have to offer ambulatory services, emergency services, pediatric services, including oral and dental, hospital, maternity and newborn care, prescription drugs, rehab services, lab services, and there is a significant attention of wellness services and chronic disease management in the Affordable Care Act. Also has to cover mental health and substance abuse disorders, which is creating more parity. How are a lot of people that are still left out of the Affordable Care Act? Who's left out? Immigrants and undocumented immigrants. Members of Congress, mainly Republicans, said that there was absolutely no way that they would vote for Obamacare if immigrants and undocumented immigrants included. And then also, people left out will be people in states who have chosen not to do a Medicaid expansion. So far is that the U.S. Supreme Court ruled that the individual mandate is constitutional. Insurance out of the child-only market, which I mentioned, and also there are corporations who have asked for and received waivers. Best example is McDonald's. So is that every company has to set up insurance plans. They have to at least offer, a bronze plan. That they need a waiver because their employees usually work part-time and they only make minimum wage, so they would not be able to afford level the bronze plan. They couldn't afford the premiums. So actually we're given a waiver. Important piece of the Affordable Care Act, which is directly linked from care, is the Class Act. The Act was part of the Affordable Care Act, and what it said was that employers offer their employees long-term care insurance. And get a lot of people to actually long-term care insurance is they're going to use an opt-out method versus an opt-in. So you have to opt out from your employer to take this out of your paycheck, and a lot of people doubt of things so that a lot of people would be covered, and some of them may not even know it. However, Catherine Sebelius, the Secretary of Human Services, saw that as unaffordable, and it has, and the decision was made that it will not be implemented as part of the Affordable Care Act. Of ACA is that over-the-counter drugs are now excluded from medical savings plans. For those of you who have medical savings plans, which I certainly do, before this act was, before 2010, at the end of the year, if you had money left over in your medical savings plan, you could sign up on your over-the-counter drugs like Colton and vitamins and aspirin. Now you are no longer allowed to do that. Another cap, one of the ways we're going to pay for it is individuals who want to partake in indoor tanning services have to pay 10% tax on top of the fee to use the tanning service. And this is based on the fact that there is pretty strong, significant evidence that tanning leads to cancer. Another happened is in 2012, when the health insurance rebates were given back to individuals, $1.3 billion worth of premium rebates were given back to individuals who bought insurance. And it was very confusing because many of these individuals had no idea why they were getting this money back because we didn't market that part of the plan very well. What already happened is hospitals have started to deal with readmission penalties. In the lay population is that this applies to all hospitals. The readmission penalties are for hospitals who are below the national average for readmission rates. What happens so far with the Affordable Care Act is that small businesses have gotten an extension for the individual mandate until 2015, and corporations also do not have to comply with the individual mandate until 2015, which is a significant problem since the vast majority individuals in the United States are going to be covered by their employers. So there is some question about how can we enforce the individual mandate beginning the taxes, 2014 tax cycle if employers aren't required to comply until 2015. So I wanted to expose to the YouTube, get ready for Obamacare. The Kaiser Family Foundation, actually, if you want to know anything about the Affordable Care, it is the best source of information that you can find on the internet. They have a previous cartoon, which was the Affordable Care Act hits Main Street, which is a good way to get a good overview of the Affordable Care Act. And this particular cartoon actually gives you a great summary of what is going to happen between now and January 1st, 2014. Mercedes and Bob and I are hoping this is they're going to be able to get this to. So I'm going to play this for you.
Vicky, will you scroll it down a little bit so people can see? There's a scroll bar on the side.
Is this?
I can't see it, so can you scroll it down?
Like there?
I'm still not seeing. I don't know if other. Well, maybe I need to do it myself. Okay, never mind. If you can't see it, scroll it down yourself. Yeah, listeners. Okay, let's try it.
Here we go.
Well, it's finally happening. After years of drama on Capitol Hill, a Supreme Court case, a presidential election, and a Mayan apocalypse that could have stopped it dead in its tracks, but didn't. Our key elements of the Affordable Care Act, sometimes called Obamacare, are about to kick in. And bigs are coming to health insurance in 2014. In the next minutes, you'll get a pretty good lay of the land by once again watching your fellow Americans, the U-Tunes, find their way through the system. There are 4 main ways nearly all of us will experience health care once the health reform law goes fully into effect. About half insurance through our jobs, just like today. About a third will get covered by the government through Medicare and Medicaid. About 1 in 10 will buy insurance themselves. And unfortunately, another 3 million of us or so, just under 1 in 10, still may not have coverage at all. But the workplace. Many of them are already covered by their employers, and for them, not a whole lot will change. There will be new advantages, though, like caps on how much you have to pay out of pocket, and free preventive care. The bigger those who work for larger companies but aren't covered now. That's because the government is going to require companies with 50 or more employees to cover full-time workers. Get them penalty. So more workers may find themselves covered. Employers won't face the same penalties for refusing to buy insurance, but they'll be encouraged to do so. We'll be setting up special marketplaces to make it easier for small employers to take the plunge. Some will be offered temporary tax breaks if they do. And unlike now, insurers can't inflate prices if some employees are sick. Some of us will be getting covered at work. A lot of us will be covered with help from the government, just like today. Not change for seniors on Medicare. The law's already started helping with prescription drugs and better preventative care, and that will continue. Medicaid, on the other hand, is expanding to cover more of us, especially poor adults, many of whom aren't eligible today. If your is low, they'll cover you, most likely in a private insurance plan. But there's a catch. The Supreme Court ruled that governors and legislatures of each state should decide whether or not to be part of expanding Medicaid. In states that get on board, the feds cover almost all the cost. you may be left with the same options you have today if you're poor. So check out your state's decision if you think you might qualify for Medicaid. Even employer coverage and the expansion of Medicaid, a lot of still be left out. For covered or who find their work coverage too expensive, a new way to buy insurance on our own will be popping up everywhere. They're called health insurance marketplaces, though they have a fancier name than that in your state. The health marketplace is like a virtual insurance mega mall. You'll find private insurers competing for your business, and you'll be able to pick out how much coverage you want and what you want to pay for it. From high-deductible bronze plans to more expensive platinum plans. Still, all plans will cover a comprehensive set of services like hospital and doctor visits, maternity care, mental health care, and drugs. Most everything any of us need, at least when it comes to medical care. Not all governors are on board to set up these marketplaces, but the feds will open their own in those states, and so you probably won't notice much of a difference. The big advantage of buying insurance through these new marketplaces is that the federal government will provide most people with a tax credit to make insurance more affordable if you don't have any other options and your income below a certain level. If most people buying on their own will be eligible for a tax credit and won't have to pay the whole premium themselves. And the market will make sure that insurance companies operate fairly under strict rules. They have to offer everyone insurance, even if they're sick. They won't be able to charge more for pre-existing conditions. Unlike men and women will pay the same price. And prices come down, while people will pay more. Cost down for young people, though they'll be able to stay on their parents' plans until 26. Buy low-budget catastrophic plans until they're 30. All these changes still don't mean insurance will come cheap. Most people buying their own coverage will end up paying less with the new health insurance tax credits, but people will have to pay more, even though many of them will be getting better and more secure insurance. So let's be realistic. Not everyone's going to run out and buy insurance. Some might say, hold on a minute. If I can't be turned down or charged more, why not wait until I get sick or injured to buy insurance at all? You can only get coverage during special enrollment periods, so snooze, you may lose. And second, thanks to something called the individual mandate, if you're not insured, you pay a fine, making this option seem not nearly so clever. Still, if you really can't afford to buy in and can't get insurance anywhere else, the government will waive the penalty. So don't panic. By now, you noticed a lot more people will be getting a lot more coverage. Where will the money to pay for that come from? Taxes. Many of them targeted at the health industry itself, even canning services. You will pay too, mostly the wealthiest Americans who will be paying more into Medicare. Also, hospitals and insurance companies participating in Medicare will get paid somewhat less. Nameless, but somebody's got to pay. So, prepare for 2014. How will you be covered? How would you like to be? Now's the time to figure it out and get on the path of setting yourself up for the best insurance at the best price. After all, who wouldn't want that?
Foundation website not only has the videos, but you're not quite sure how the Medicaid expansion and the health insurance exchanges are going to be working in your state. It's a really good place to get information about your state's plan under the Affordable Care Act. Part of the presentation really focuses on what are the implications of the Affordable Care Act for social work. So there are three opportunities that are presented for social work as a professional Affordable Care Act. The first is patient navigation, because patients need to, all eligible people need to enroll. So we need a process for Medicaid, for the Children's Health Insurance Program, and the health insurance exchange premium credit. and state required to set up navigator programs through insurance exchanges, and certainly social workers have the skills to do. Every state gets to determine how they're going to set up their navigator programs. I'm in New York State, and I know that an RFP that was sent out, and there were 6 that were chosen navigators. Part of it was that the navigators that were chosen have not been people who traditionally have enrolled people in Medicaid, or they weren't departments of social service or county level agencies, mainly through the state private vendors. Also, our focus on populations we serve, the underinsured and the uninsured. The Affordable Care Act is care coordination, which is that wording is sprinkled throughout the law, and the focus is on patient-centered medical homes and accountable care organizations, with the idea being that we want to keep people in their homes as long as possible, and also we want their care to be managed well and coordinated. However, is that the phone rule on the accountable care organizations does not include social work as a profession that can help in the accountable care organization. The patient-centered medical home is dependent upon a reimbursement structure, whether social workers are included or not. We also need research to show our worth. It's still very much lacking. I actually published a paper in 2006 that looked at social workers in the field of aging, and some research, I'm doing an update to that, and there actually is less research this time than there was in the last meta-analysis that I did. With the main point being that even though social workers are involved in interventions, when the interventions are published in peer-reviewed journals, the identity of the interventionist is not identified. So it doesn't say whether it's a social worker or a nurse. Which certainly impacts nursing home social work and long-term care social work is transitions in care. There's an entire section of the Affordable Care Act that focuses on transitions in care, and this is focused on high-cost individuals who are in the community. They end up in the ER, they end up in the nursing home, then they end up back in the community, and it's making their care more appropriately. The other area that is an implication for social work is behavioral health treatment. 30 million people who are going to gain coverage for behavioral health services under the Affordable Care Act, which is going to trigger significant demand, could trigger significant demand for services. And at this point, we actually have a workforce shortage. So we would be able to actually serve 30 million individuals in the system. And MAGI, which is the Medicaid Adjusted Gross Income Population, which is the population of individuals who will become eligible for Medicaid under the Affordable Care Act. In relation, there are higher rates of behavioral health issues when compared to others, which means that the need will be greater. Social workers are also going to need to adapt to Medicaid as a big payer. For example, in New York State, we have the largest Medicaid population. We have 5 million Medicaid beneficiaries, and that's even before our expansion. So there are going to be a lot more Medicaid clients. Social workers, individually and also in the host agencies that they work with, are going to have to really cultivate strong ties with state Medicaid agencies. Care, which is not expertise, but Section 3026 of the Affordable Care Act actually focuses on community-based care transitions. It's a community care transitions program. I've included the link for you here so that you can look at the program funding and the that are included in the Affordable Care Act for transitions in care. So this particular program provides direct funding to community-based organizations to provide transition services to high-risk Medicare beneficiaries who are discharged from acute care hospitals. And some states are really pushing to increase the number of individuals who are actually in nursing homes as part of the Affordable Care Act. And just a little earlier than I thought I would, here are some resources. The Council on Social Work Education actually has an excellent resource guide for social workers gives an overview of the Patient Protection and Affordable Care Act, and as I stated before, the Kaiser Family Foundation as well. Questions that individuals have?
If you have any questions, please go ahead and put them in the Q&A box or in the chat box if that's easier, and we will go through the questions. I'm take, or Vicki, you still have the presenter. Whenever you change the slides, everybody's seeing what you're changing because you have the presenter power. I have a question here. Will there be training for the Medicaid and HIE premium credits? This is a general problem in nursing homes. Do you have a response to that, Vicki?
For credits?
Oh, I'm sorry, I didn't have my phone on right. It says, will there be training for these Medicaid and HIE credits?
Yeah, so that is the Medicaid and HIE, the Health Insurance Exchange Credits, the training, the Affordable Care Act. It's on a state-by-state basis, and every state is going to market it in their own way. It's supposed to be providing training to professionals in the community, as well as offering public service announcements and things to individuals in the community. So every state is different. I do know that in New York State, the Department of Health and the Office for Medicaid is actually going around, all around the state to different counties. They've already started now to discuss the health insurance exchanges and how individuals can actually sign up during the open enrollment period. But it's not full, and I know in New York State, it's not fully, all of the information for who's eligible as of 2014, all of that, it's not even on their website yet. But the federal government knows that there's a big disconnect between the Affordable Care Act and what the general public actually knows about the Affordable Care Act and how to apply. So beginning first, there is supposed to be a lot of public service announcements and information that's going to be available to individuals for how to sign up for open enrollment.
Okay, thank you. Back on slide number 20, you were talking about, I don't know if you can move thank you. You're talking about the accountable care organizations. What are the accountable care organizations? So you're on 19 now. There you go, 20.
Accountable care organizations are organizations, and at least that I'm in, many of the accountable care organizations are hospitals. So what an accountable care organization is a hospital or a healthcare system where you have the service of the physician, the social worker, the OT, and they are like a group practice, way to describe it. And they're paid so much money for each person. And if they're accountable because if they provide good care and people's health care is managed well, the individuals will cost less and they get paid incentives. They get back. Your issue with accountable care organizations is then who within that organization gets the money? Like is it a hospital, is it a physician practice, is it to workers? But it's them accountable for the care they provide to clients. And there's incentives to keep people well, and you get paid bonuses.
Is that for Medicare people, the accountable care organizations, or is it for the whole population?
It's the whole population. It's
okay.
The whole population.
Their question, does the Affordable Care Act affect people who are receiving Medicare and they're wanting to purchase supplemental insurance?
I don't know of anything in the Affordable Care Act that will impact that.
Okay, I forgot. On this same slide, number 20, it says that you mentioned that social workers were not mentioned as included. general rule on ACOs does not include social work. Well, other professions included, and social work was not, or no professions were included by name?
No, others were. Physical therapy, occupational therapy, nursing, physicians, other professions were. And, I've talked with Nancy Poyman and some other people, Pat Mullins and other people in the field, and part of the issue is that social workers are directly mentioned in the Social Security Act, which is hard to believe. And also when they have actually with officials CMS, what CMS says is we don't have enough evidence that you do is distinctly unique from what these other professions do.
Thank you for clarifying that. If there are other questions, please go ahead and put it in the box, the Q&A box, or in the chat box. Otherwise, I'm going to just keep asking some questions. As I think about what's facing our nursing home social workers, it sounds like the emphasis on readmissions is really going to be affecting nursing homes, because if hospitals are going to be financially penalized if he is readmitted too soon, then I'm assuming that nursing homes are going to get the message that they're not supposed to be sending people to the hospital as freely as they have in the past. What do you think about that?
I think that could definitely be an issue. Like have individuals that may not necessarily be acutely, but have some issues. Yes, it is going to impact hospitals accepting people also from assisted living.
Mm-hmm.
Because there was a frontline. I don't know if anyone saw this. A frontline special on assisted living facilities this weekend. They're also accepting more complex patients that actually should be in nursing homes, and they're getting readmitted to hospitals as well. So I think that it definitely, I don't think we're seeing yet, but I definitely think that could have an impact, a negative impact.
Could be negative, but also if these accountable care organizations that are run mostly by hospitals also would include nursing homes, then perhaps there'd be more support in nursing homes to keep the residents in the nursing home if it's in the residents' best interest. Because now we're just exposed. The hospital reimbursement is completely separate from the nursing home reimbursement, and when short staff in other areas, we see a lot of patients being transferred because of reasons related to staffing, not so much about patient care needs. So hopefully this will make things a little bit better. I agree with
you. I think accountable care organizations and patient-centered medical homes should include nursing homes and assisted living facilities as active partners, so that there's communication between the different levels of care. You can figure out how to best manage a patient.
Another question. If a huge number of new individuals who were previously without coverage into the system, will this affect the demand and the provision of healthcare services? I mean, in other words, are there going to be enough primary care physicians and mental health service providers, etc.?
I think that has the potential to be a huge problem. We already have a shortage of primary care physicians. We have a shortage of social workers to work with older adults. We don't have enough mental health professionals. So there are real concerns among the profession in the healthcare industry itself and policymakers that we're not going to be able to meet the demand. So another piece of ACA, actually, there is funding in there to train more primary care physicians, because the Affordable Care Act really demands not specialists. It demands primary care. And so one of the major questions that we're not going to know until people enrolled is, one of the unintended consequences going to be that people now have health insurance, but they have no access to health care. Can't access services. As this is gearing up, there are also, even existing doctors are refusing. I just moved from New York City, and our physicians who are refusing to accept Medicare patients, they're refusing to accept Medicaid patients. There are physicians who are refusing to accept insurance at all and only accept private pay. So a workforce shortage as we enroll these 30 million more people is a very real concern.
So there's going to be a clear demand for more primary care specialists and mental health specialists. And in the past, our healthcare system, our healthcare providers were folks setting up kind of as a single shop, what do they want to do? And now it sounds like for the first time, we're saying, well, what does the country need? Specialists does the country need versus what does the country actually need? So it may take a little while, but we will eventually get people going into these fields who want to help meet the country's needs.
Right.
That might be part of it.
Exactly. And the Affordable Care Act does begins to shift. It's trying to shift our attention from acute crises to more prevention. There are a lot of provisions in the Affordable Care Act for more prevention. For example, one of the things, individuals 65 and older who are on Medicare, they can have a 1-year visit. It's not a physical. It's where you sit down and talk to your doctor about your health. It's like a recurring visit, so to speak. And care will pay for that. So it's more preventive than it is you have something going on and you need to go in and see the doctor.
I think that's important. As I listen to the news and, I hear about the contention related to the Affordable Care Act, I'm conscious of the words that we use and how the framing of this important act is affecting how people think about it, even if people don't know that much about the actual act. They're hearing how it's framed. And one of my pet peeves is the whole issue of individual mandate, because nobody likes to be mandated to do anything. And I choose to think of it as individual open door, because we are now setting up a system where states have an incentive to open the door to insurance to people who've been facing a closed door for the history of this country. And so, yes, people are required to buy insurance, but there's an awful lot of assistance for people who would have trouble affording it. And so I just think that, any piece of major legislation like this is going to have some warts on it. There's no two ways about it, because that's part of being a democracy, having to satisfy so many different voices. But from what I understand of the Affordable Care Act, it seems like there's going to be a way for many people who have been marginalized and left out to get in the system. And when I think about nursing home social workers, I'm not thinking so much about the residents we serve, but I'm thinking about the people who work in nursing homes who themselves may not have health care insurance. And so, I'm hoping the social workers, as we learn more about this, will help the side nurse aides and the dietary aides and the people there know that even if they're not working full-time, because, that's our history in this country is full-time employment is your ticket to health insurance. Well, as everybody on this phone call knows, many nursing home employees are not full-time, so they may not be getting health insurance benefits through their employer. But now, for the first time, the working poor and other low-income people will have help from government to get health insurance for themselves and for their children. And I really hope that our nursing home social workers can help get that word out to fellow workers. Any response to that?
Oh, I think that is insightful and important, because I think it's not just our clients; it is our people that are working with us and taking care of older adults, and certainly the CNAs and the home health aides. Those folks that really are not making a lot of money and are having a difficult time affording insurance. And I think it's important that social workers working in whether you're working in a home health care agency, a long-term care agency, tell those employees understand, because they're not understand how they can get insurance and get credits to get insurance, because they're not. The one place where Obamacare fails abysmally is we are not getting the word out to the people.
Yeah.
People don't understand it. They don't understand how to enroll. They don't know what they're eligible for. And, at least I know in New York State, we have given these contracts to navigators that are like managed care corporations.
Yeah.
Instead of like the county DSS, who knows how to reach the people who need the expanded Medicaid.
Yeah. Yeah, that's a very, very important point too. And just make sure, the expanded Medicaid is a huge benefit, but the budget to pay for marketing was not provided. It's not a very strong budget. I know here in the state of Iowa, our navigators don't have much money to get the word out. So the navigators are being competed to get a grant to help answer people's questions, but first people have to know that the navigators exist and that there is a place to get questions answered.
Absolutely.
So, another question, does the Affordable Care Act requirement for mental health care specify the type of diagnoses to be treated?
No, it doesn't. That's less. So the way the Affordable Care Act is, it mandates the 10 essential services, and then it leaves it up to the states to approve health insurance plans. So each state has usually a health insurance inspector's department or something with the same, reviews health insurance plans and says whether they're acceptable and will be approved in the state or not. So I think that every state's mental health component of their insurance under either the Medicaid expansion or in the health insurance exchanges is a little bit different. ACA just further validates mental health parity, that, mental health issues have to be treated the same as any other illness.
Will to go through a physician to get or are they able to go to like a licensed clinical social worker directly, or are they going to have that physician approval? I don't know if those kind of details are available yet.
They're not enough. That's going to depend on the insurance. This is why it's so important with navigators. So if you have someone who is eligible under the Medicaid expansion, and say they already have a diagnosable mental health issue, right? And trying to go online by themselves and try to figure out which of the plans is going to best serve what's going on for them, it's difficult for them to do on their own, which is why their programs were stopped. But like you said, like in Iowa, no one knows they exist. I see very much the same as this expansion of Medicaid, very much the same as what happened when Medicare Part D came into effect. And they said, just go to the CMS website and you can go into your state and you can see what drug plans are available. Adults didn't have a clue how to do this by themselves. And I can tell you, 27-year-olds aren't going to have a clue how to do it in this health insurance exchange. So the actual mental health services are going to be program specific, and you're going to have to pick. It'll be different. If it's a bronze health plan, there'll probably be less, and if it's a flat plan, you'll get a lot more. The code will be different. The number of sessions will be different. You have to, get approval from a primary care physician first. Will be different. And, just generally, even very highly educated people, look, if I went to my school and asked my colleagues if they've read their health insurance policy, maybe one will have read it. Highly educated people, right? So people who are going to be getting insurance for the first time, do you think they're going to be savvy consumers who could get these health insurance exchanges and pick the best plan for them and their family? It's not really.
Yeah,
because
you're right.
Like, so there are physicians on the bus line.
And I'm also just trying to think in the last 12 minutes or so, what's the important take-home messages will be for nursing home social workers. And so since most of the people that are nursing home residents are receiving Medicaid and or Medicare, it doesn't look like there's going to be a lot of changes in the residents' reimbursement other than this disincentive for people to be readmitted, the disincentive to the hospital to have people readmitted within 30 days for the same diagnosis or for the same type of treatment. But I'm just also trying to think, what else should our social workers be aware of or be thinking about? And, so know that every state has navigators, and a lot of the information will be online. But for people who are not socialized to have ever had health insurance before, which is literally millions of people in this country, I agree with you, Vicki. It's going to take more than slapping some information up on the web or putting it on a brochure or something. People need to talk through to really understand this subculture of insurance. And that's the other issue that we're dealing with here in the United States. No other country had to figure out how to keep private health insurances in business to develop their health plans. But that was one of the things politically in our country we needed to, the leaders were saying, some leaders were saying, we're not going to go along with anything that hurts the insurance company. So yes, it is complicated, but it's complicated in part because the people who crafted this law were required to include a role for private health companies.
Well, I think the one important thing, just in terms of nursing home social workers, and I'm using New York State as a case example. New York State has been proactive response to Medicaid expansion. We have very expensive, most of our money is spent on nursing home care and Medicaid in New York State, and so they actually proactively, in response to ACA, before they even have enrolled anyone in the Medicaid expansion, they have totally redesigned their Medicaid program. So I think social workers in long-term care and nursing homes I think other states may start to do this as they see what happens under ACA, so that individuals, when they are now in long-term care Medicaid in New York State, they have to mandatorily enroll in managed care Medicaid products. This is where they get into the nursing home. There's this significant push in the state, and I'm not saying it's right, and I predict that it's going to backfire abysmally, is to keep people in nursing homes at all costs because it's too expensive. But the issue is we not have enough community-based social workers. So we don't have people who managed care and mandated, they're not wanting to put them in nursing homes. We have huge waiting lists for community-based services because there's a workforce shortage. So that can add Medicaid costs. Right now, the federal government is covering 100% of the expansion, but I think states are going to begin to look at their long-term Medicaid expenses and their other Medicaid expenses. And I know New York State, it is already really, it's caused a shakeup in the whole long-term care system.
Seeing a lot of states take a good hard look at this, and nursing home care is expensive, but it's a drop in the bucket compared to hospital care.
Oh, absolutely.
So my secret little wish, perhaps when these accountable care organizations start really taking seriously not wanting to readmit people within 30 days, that we actually see a push for higher staffing levels in nursing homes, because the staff was adequately trained and there were enough people there in the nursing home, many hospitalizations could be prevented or without sacrificing care. So I think what we need to remember in part is, yes, this is it's a complicated piece of legislation. This is a huge part of the American economy, let's face it. But how do we make this good for nursing home residents and for the people who work in nursing homes. And I think there are many potential benefits, especially for direct care workers who right now who don't have access to health care for themselves or for their families. And so I'm really hoping that the Affordable Care Act may end up really helping people who work in nursing homes. And,
that's a really good point. If people are well, and they're not stressed out about worrying about their own health care or their children's health care, they're going to be able to do a better job.
Yeah.
Be able to be at work and be healthy.
And more with a bigger emphasis on primary care, that it's not going to, eventually it's not going to be difficult to get access to a primary care person when there's more of them around. But right now, the primary care people are leaving school in very high debt, and they're not going to be making the money that the specialists are. So this law really changes financial incentives for organizations and for providers and for consumers, and I think in general in ways that have needed to be changed for a very long time. So the incentives are starting, they're in the right place, and now we've got to edit ourselves and also educate our communities and make it work to the extent that we can. We had a comment here, very informative presentation, and thank you. And so I want to thank you, Vicki, and also Bob Conley for making this talk possible. Very interesting, and I hope you'll come back in the spring and talk with us again about how things have changed. The open enrollment, as you mentioned, starts October 1st.
It'll be a different picture in the spring.
So many things are happening so quickly. It's like herding cats in a way. But we also need to take them by the horns and do what we can to connect people with needed health insurance. So thank you, everybody, for being online with us today. The session recording will be posted within 24 hours. Please do fill out the evaluation form when you sign off, and know that we're always interested in your ideas. If you have ideas for a upcoming webinar, let us know, and we'll see what we can do. So signing off for the National Nursing Home Social Work Network. Have a good day, everybody, and thanks for joining us. Bye.
Bye-bye.
I loved your comments. You did a really nice job of pulling out some really important points. That was nicely done.